musculoskeletal fellowship training at University of Sao Paulo Medical School, where he served also as a director of radiology at the Orthopedics Institute and or director of musculoskeletal radiology at the Institute of Radiology. He also did a musculoskeletal radiology research fellowship in Brussels, Belgium, and also in New York, USA. Currently, he is the Chief of Radiology Department at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. He has edited 6 books, authored 30 plus chapters, 70 plus peer reviewed publications, and he is member of all the well renowned societies across the world. And currently, he serves on the ISS Executive Committee and on the editorial board of Skeletal Radiology. So it's a complete pleasure to have you over here, sir. Thank you so much for accepting the invitation. And I know it's going to be an enlightening one, and I am pretty excited about it. So thank you so much. So I would request you to share your screen.
Thank you, Ankita, for your kind introduction. Let me share the screen.
Yes, we can see. We just need to go in the presentation mode. I can see your, yeah, sir, perfect.
Now it's good?
Yes, sir, good to go.
Okay. So, hello, everyone. For me, it's good afternoon. I'm in Doha, Qatar. For you, it's good evening. So it is a pleasure to talk here in the webinar. And I'll show a little bit of our experience here in Aspetar, which is a sports medicine and orthopedic hospital in muscle injuries, okay? I've been there in Jaipur and I had a great time there. I met a lot of amazing people and I really love the level of the musculoskeletal radiology in India, really high level, and this encourages us to always grow. So it is a real pleasure to talk to all of you. So I'm going to talk about the role of imaging in muscle injuries, a little bit of our experience here in Aspetar. We do professional and amateur sports here in Aspetar, and of course, muscle injuries is the most common injuries in sports. And so I'm going to show a little bit of our experience here, okay? So before we start, I'm going to show an ultrasound of the posterior thigh, posterior proximal thigh. This is a transverse image of the posterior thigh. So at hamstrings, we're looking at the hamstrings here. And I want you to take a look in this image and try to make a diagnosis of what you're seeing. Of course, ultrasound is dynamic, but I think we can have a good overview here. I'm just going to show, this is the semitendinosus. This is the biceps femoris. This is the sciatic nerve. And I'm going to show you an image of a normal hamstring ultrasound just for you to compare and see what's different, okay? So we're going to come back later in the lecture, okay, showing this case, but I think we can already see some things here. Keep this in your mind and we're going to come back, okay? Very good. So our content, I'm going to talk a little bit about muscle morphology, anatomy, and especially on ultrasound and MRI, the types of tears, classification, why do you use MRI and why do we use ultrasound? So I'm going to go through all of this. So the muscle anatomy, we have involving the muscle, the epimysium. So the epimysium is analogous to the muscle aponeurosis, the muscle fascia. This is the connective tissue that involves the muscle. We also have the perimysium, which is involving the muscle fascicle, okay? And we also have the endomysium, which involves the muscle fibers. So a muscle is composed of fascicles, which by itself is composed of fibers. and which involves the muscle, is the epimysium, the fascicle perimysium, and the fiber, the endomysium. So the epimysium, which involves the muscle, we can see the epimysium on ultrasound as thin echogenic lines, and also on MR as a thin hyposignal line, okay? The perimysium on ultrasound, we can see as thin echogenic lines. However, we cannot see the perimysium on MRI. And the endomysium, we don't see it neither on ultrasound, neither on MRI. So we still don't have the resolution on the normal clinical ultrasound and MRI scans to see the endomysium, which is going to involve the muscle fiber. We have some types of muscle injuries. The indirect tears are the most common ones, and they are divided in these kind of tears. We're going to talk about them. We also have the delayed onset muscle soreness. So after exercise, there is increased vascularity, and the muscle can increase its volume, giving a clinical symptom, okay, which is called the DOMS. And we can see the DOMS on MRI. The direct tears or muscle contusions are by a direct muscle injury. Okay, we can have muscle hernias, and we can have chronic exertional compartment syndromes. We're going to talk especially about the indirect tears, which are the most common kind of tears. So indirect tears, let's go first to the myofascial tear, which is a tear of the aponeurosis or the epimysium, okay? We can see this kind of tear on both MRI and ultrasound. We're gonna find surrounding edema, also seen on both MRI and ultrasound. And we can have this architectural distortion, which is best seen on ultrasound. Okay, so let's show example. So here we have an MRI with a myofascial tear. We can see the tear itself of the fascia, that's continuity of the fascia. We don't see that hyposignal line here at the surface of the muscle. There's some fluid here, and we also have this surrounding edema in the surrounding muscle fibers, okay? On ultrasound, it's the same thing. We can see the discontinuity of the fascia. We have this surrounding edema, which on ultrasound is going to appear. It can appear as hypoechogenic, but also appears as hyperechogenic, as we can see here in this case. And we can see that there is architectural distortion. We can see that there is discontinuity here of the muscle fascicles, the perimysium. We can see its continuity of the perimysium. So we can see this architectural distortion on ultrasound. Another kind of indirect tear is the intramuscular tear, which we're going to see. We can see architectural distortion, especially on ultrasound. On MRI, it's very difficult to see this. We can see the surrounding edema on both methods, MRI and ultrasound. And here's an example. Here's the rectus femoris, a transverse image. Here's the direct tendon. And you can see here that there is a discontinuity of the muscle fibers with this hyperechogenicity surrounding, which corresponds to the muscle edema. This is the correspondent MRI of this patient. We can see the discontinuity and the surrounding muscle edema. So this is the intramuscular tear, which is different from the myotendinous tear. So the difference is that the intramuscular tear is a tear in the muscle far from the central tendon or the central connective tissue. The myotendinous tear is a tear in the muscle next at its attachment to the connective tissue or the intramuscular tendon, okay? So we can also see the architectural distortion on ultrasound. Sometimes we can see it on MRI. I'm going to show some cases. The surrounding edema on both methods. And we can also see that in this case, the central tendon is going to be intact, okay? So here are some examples of the myotendinous tear. So we're going to see this muscle edema next to the central connective tissue or the central intramuscular tendon. On the MRI, we have this typical feathery appearance. We can see because of the edema next to the muscle fiber attachment in the central tendon, we can see the architecture here. Sometimes it's distorted, sometimes it's not, okay? And on ultrasound, we can see the muscle edema surrounding the central tendon, here both on transverse and longitudinal images. Another case, another rectus femoris with a myotendinous junction tear, edema surrounding the central tendon, which is intact, both on MRI and on the correspondent ultrasound image. We can see that the central tendon here is intact on both methods. And also a fluid field lesion here surrounding the tendon on MRI and also on ultrasound, okay? And also the surrounding edema on MRI with hypersignal and on ultrasound with hyperechogenicity, okay? And the other type of indirect tear is the intratendinous tear. So here we can see a tear in the central tendon on both methods, MRI and ultrasound. There is, it can have loss of tension of the central tendon, which is best seen on MRI. Sometimes we can see it on ultrasound. Architectural distortion, best seen on ultrasound. Sometimes we can see on MRI as well. And the surrounding edema we can see on both methods. So here we have a lesion with edema at the biceps, distal biceps femoris T-junction tear, with a tear here at the bicipital tendon, the distal tendon, okay, the zipper component between the short and the long heads. And we can also see this tear on the longitudinal ultrasound image with the surrounding edema and architectural distortion. Another case of now the rectus femoris, we can see that the central tendon is completely injured. Here we don't see that normal thin hyposignal line. We can see that there is a tear at the central tendon with the surrounding edema, and the central tendon's continuity is best appreciated on the coronal or sagittal images. And on ultrasound, we can see that the central tendon is not characterized and the surrounding edema here on ultrasound as well, okay? So this is the intratendinous tear seen on both MRI and ultrasound, okay? So these indirect muscle injuries are associated with acute pain in the athlete, the professional athlete, the amateur athlete. There is no direct trauma. Usually it's limited to one muscle compartment. And of course, this is gonna limit the physical activity. Clinical classification of muscle injuries exists since a long time ago. The most known one is this one described by O'Donoghue in 1962, and it refers to pain and function of the muscle, and it divides in 3 grades of injury based on clinical symptoms and function of the muscle. Why should we classify the muscle injuries? First, for injury staging, so this is going to give a prognosis, which is very important in professional sports. Second, to plan the best treatment. So depending on the classification, the injury grade, it's going to be conservative versus surgical treatment. Eventually, we can have intervention like hematoma aspirations, like injections of PRP, for example, and also for re-injury prevention, secondary prevention. Depending on the classification, the grade of the muscle injury, we can make a prognosis in the chances of a re-injury after treatment, okay? And how to classify. So there are various classification systems. We have the 3-grade classification, which is based on that first clinical classification that I showed you before, and it's divided in grade 1, grade 2, and grade 3. This one, for example, there's only edema of the muscle. There's no fiber discontinuity, so this lesion is a grade 1. There's the BAMIC classification, which is the British Athletics Muscle Injury Classification System. So it also evaluates the discontinuity of fibers and also the involvement if it's either a myofascial, if it's a myotendinous and intramuscular, and if it's an intratendinous tear. So the C injuries are the intratendinous tear. You can see here that there is a tear of the central tendon with the surrounding muscle edema, and depending on the extent of the edema and the lesion in the tendon, it's either grade 2, grade 3, or grade 4. So this is a grade 2 C injury according to the BAMIC. According to the Munich classification, it's a grade 3A, and according to the Barcelona ASPETAR, it's a grade, it's a very complicated classification, IP, PM, G1R, RO. So it's quite of a cumbersome classification to use in our day-to-day basis. It's not only imaging, it's based also in clinical aspects. So to use in our day-to-day basis, it's a very complicated classification. Okay. So let's go through these classifications. So we have the most simplified one, the 3-grade classification. And we have 3 types of injuries here. So we have a grade 1 only with edema. We have a grade 2 with discontinuity of muscle fibers less than 50% of the cross-sectional area of the muscle, or we have the grade 3, which is a complete muscle or tendinous tear of the muscle. Here you can see it's a complete tear of the origin of the hamstring with the distal retraction. Okay, so this is the 3-grade classification. Why should we use MRI to classify? First, and to diagnose the muscle injuries. First, because it's a gold standard for muscle injuries. Second, it's gonna visualize acute and lower grade injuries, so it has a greater sensitivity compared to ultrasound. It's gonna evaluate deep and proximal muscles, and it's also gonna evaluate the re-injury risk of a muscle tear after treatment. And also, it's more reproducible, less operator dependent than ultrasound, okay? And why to use ultrasound? It's available, low cost, it's a faster examination, it has an excellent spatial resolution according to the muscle architecture. It allows dynamic evaluation, it allows imaging guided procedures, and it's operator dependent. Okay, so here's a football player with acute right distal thigh injury during a match. You can see here the distal long head of the biceps femoris. Here you can see a tear of the tendon. That's continuity. And here we can see a hematoma associated with this injury. And here you can see the hematoma. Okay, on ultrasound, you can use ultrasound to aspirate hematoma. Every time you aspirate a hematoma, there is a greater chance of healing of the muscle. Okay. A problem we have on classification is a large spectrum on grade 2 tears. For example, here we have 5 grade 2 tears. So do you think this grade 2 tear is similar to this one, to this one, to this one, and to this one? No, I don't think so. So the disadvantage of using the simplified classification, we don't give a real prognosis for the clinicians and for the sports medicine doctors and for the orthopedists to treat this patient. So this is a much simple grade 2 class injury compared to this one, the last one, which is a more severe grade 2 injury. Okay, so the disadvantage of the simplified, the 3-scale classification, it will not give the prognosis in a proper way. Okay, it's more simple to classify, but it won't give the prognosis in a proper way for treatment of this athlete. Okay, here's another patient. Here's a grade 2 injury. Okay, although it is a complete tear of the tendon. Okay, so actually it's a grade 2 on the 3-scale classification. However, on the BAMIC, which is a more used classification for professional sports, it is a more advanced. It's a grade 4 because there is a complete tear of the intramuscular tendon. Okay, and depending on the grade, you can predict the return to play. You can see here that the lower the grade, the lower the less time you have for return to play, and vice versa. The higher the grade, longer is the return to play. Okay. So this is the 3-scale classification. So the Munich classification, another classification, is the first classification to use the injury mechanism. So it's not only imaging, it has clinical parameters to it. And what is important for us radiologists are these 3A and 3B and the 4 grades, which involves radiology. In this classification, it localizes the injury. So it says if it's in what muscle, it's very important to say what muscle, and if it's proximal, middle, or distal. Okay. The injury extension, you can have extension of the edema, you can have extension of a partial tear, or you can have extension of a tendon tear. Okay. This is the extension, the injury extension classification system. And now the British Athletics Muscle Injury Classification, which is the most used classification. Depending on the type of tear, you're going to predict the return to play. So here we can have the myofascial tear. You can see that the healing time is 3 weeks approximately. The myotendinous tear, 4 to 8 weeks. And the tendinous tear, which is more severe, is 2 to 4 months. Okay, so it gives a prognosis, a better prognosis compared to the previous classifications. The classical Federi edema, which is a myotendinous tear, you can have it with architectural distortion, as we can see here, or without architectural distortion. Of course, the architectural distortion is a worse prognosis in terms of muscle healing and, of course, in return to play. So this was the BAMIC classification, the most used one. And the Barcelona Aspetar classification, it's going to evaluate the mechanism, the localization, if it's proximal, middle, or distal, the grade, okay, this is imaging, and if there's a re-injury or not. So it's a very complicated to use in our normal day-to-day life. So although it's complete, it's going to give a very good prognosis. It's very cumbersome to use it in our daily practice. So it's less used than the other ones, although it gives a very good prognosis. So the connective tissue involvement, I already talked about it. So we know that the discontinuity of this main connective tissue or the intramuscular tendon, it has a slow, it's correlated with a slow recovery of the athletes. And we know that the intramuscular tendon injury is not associated with an increased re-injury rate within 12 months after the return to play. So this means that if there is an intramuscular tendon injury, this patient will have a longer time of recovery. The muscle and the tendon takes longer to heal compared to the other types of muscle injuries. However, it's not associated with a re-injury after the healing of this muscle tear. Okay, so here we can see the coronal image of an MRI of the hamstrings. We can see that at the level here of the tendon, the intramuscular tendon, there is a discontinuity here, and this athlete took it's going to take 2 to 4 weeks for recovery. This other lesion, we can see it's also the hamstring, the biceps tendon. You can see its continuity, complete discontinuity of the intramuscular tendon on this coronal image with architectural distortion and edema. So you can see right before the injury, you can see the intramuscular tendon on MRI, and at the level of the injury, a complete discontinuity here of the intramuscular tendon. This is going to take at least 8 weeks recovery. Of course, it's not a strict time. It can be a little bit less. It's going to be a little bit longer. This is going to depend on body composition of the athlete. It's going to depend on the type of recovery. There's other variables related to the muscle healing and return to play, but approximately 8 weeks for this type of tear. Okay. Another tear we can see here, also the biceps femoris, we can see the discontinuity of the intramuscular tendon. There is loss of tension. You can see the tendon is lax. And compared to the axial image, we can see the tendon right above already with some increased signal, a complete tear here on this axial image, and the tendon, again, normal, appearing more distal to the injury site. Okay, so also, this is a type C injury according to the BAMC with loss of tension. And this is going to take also a longer time to recovery because there is loss of tension. It's going to take a little bit longer, 9 weeks. Okay. So the main connective tissue, it's different. It's like a tree and its branches. Okay. So it gives the anatomical support and the force transmission during muscle contraction to different muscle areas, okay? So just like a tree and its branches, the main connective tissue, the main tendon, which is here, the trunk of the tree, you can see that an injury to this site is going to be a very severe injury, which can lead to longer recovery times. It's different from an injury of the more peripheral connective tissue. And that is not going to be the same as the injury at the main connective tissue, as we can see here below. So the injury to the more peripheral, secondary, even tertiary connective tissue is it has a better prognosis compared to this other one. So this is also going to affect the prognosis and the healing time of these athletes. So it's very important to say in our reports, where is it the lesion, the injury? Is it main connective tissue or is it the peripheral connective tissue? Okay, so why these classifications are not simple? You see, some are more simple, some are not. First, because of anatomical complexity. Also, there are several injury mechanisms involved in a muscle injury. Okay, there's also a functional complexity and return to activities. And prognosis is not only dependent on the morphological characteristics or localization of the injury, as I said before. There are other variables that's going to affect the prognosis and the recovery of a muscle injury. Okay, here we have a normal MRI. Okay. You can see the tendon is normal. There is no muscle edema, no injury. So an athlete that has a muscle strain with a normal MRI, this is already shown in the literature that he's going to have a fast recovery in returning to his activities. Okay, so muscle strain with a normal MRI, it has a very good prognosis. Also, a complete rupture, a grade 3 or a grade 4, depending on what classification we're talking about, is going to have a slow recovery. So normal MRI has good evidence for a fast recovery. Grade 3 or grade 4 injuries is going to have a good level of evidence for a slow recovery. Also, the rupture of the intramuscular tendon, the central tendon, has limited evidence, although it has evidence for a slow recovery. So the injury affecting the central connective tissue is related to a slow recovery. Okay, there's even this article that questioned the role of MRI in the predicting the return to play. I don't think it has its radical as that. I think MRI has a role. It can give a prognosis. We just need to understand better some characteristics, for example, the location and predicting the muscle healing. Okay. So what about ultrasound? Can it provide prognostic information? We know that it has a similar accuracy for diagnosis, except for low-grade tears, proximal deep muscle groups, and soleus muscle tears, as compared to MRI. So for these kind of tears, low-grade, proximal deep muscle groups, and soleus muscle tears, MRI is more sensitive compared to ultrasound. For the others, it's the same sensitivity. It is more available, lower cost, it's a faster examination. It has excellent spatial resolution. We saw that it shows us the muscle and tendon architectural. Sometimes MRI does not show this. It allows dynamic evaluation, which will also help us in making some diagnosis. It allows us to do image-guided procedures in muscle injury, especially hematoma aspiration and PRP injections. Okay, however, it's operator dependent. There's a learning curve for ultrasound, especially on muscles. Okay, but we believe there is a role for ultrasound on classification and prognosis. Okay, so there are already some studies on ultrasound classifications of muscle injuries. This is one from the French group, which they classified the muscle injuries in 4 grades. Also, looking at the main connective tissue involvement or not, which is related to a poor prognosis in terms of muscle injuries. So here, the M injuries with normal connective tissue and the C injuries with abnormal connective tissue. Okay, you can see that the M injuries without connective tissue involvement has a faster return to play time compared to the C injuries with connective tissue involvement. Here's an example, MR ultrasound correlation, hamstrings, posterior hamstrings. So here, let's do a close up on the MRI. We can see, and let's turn around the ultrasound, and here we compare the structures, the deep femoral vein. We can see here the sciatic, the sciatic nerve here. We can see here in the MRI that there is an injury in the intramuscular tendon, and we can see also this injury on ultrasound. Okay, this is a intratendinous tear of the muscle. So in terms of classification, there is a intratendinous tear. The BAMIC will be the C injury, and it affects more than 50% of the tendon cross-sectional area. So this is a grade 3. So according to the BAMIC, it's a grade 3C injury, and we can classify both on ultrasound and on MRI. Here we can see the injection, the PRP injection, the needle, and we can see the injection at the site of the tendon injury. So here's the tendon injury here, and the needle, and you can see the injection of the PRP right at the injury site. So the ultrasound is going to allow guiding of the injection. Okay, and this is the first case I showed before. So here is the sciatic nerve, semitendinosus, biceps femoris, and we can see that there is a blurring and ill-defined intramuscular tendon here. Okay, with this hyperechogenicity. Okay, so this, we do not depict the central conjoint tendon, just to compare with a normal ultrasound where the conjoint, the central intramuscular tendon is well depicted as a linear, thin echogenic line. And we can correlate also this injury with the MRI. So this is the MRI from this patient, the biceps femoris, semitendinosus, the sciatic nerve, and we can see here we do not depict the intramuscular tendon, okay, which is well correlated with the ultrasound image as well. And on the long axis planes, we can see the compromising of the intramuscular tendon as well. You can see the increased signal here. There's not a complete continuity of this tendon and with the surrounding muscle fiber edema. So this is a C-type injury. There is a intramuscular tendon injury according to the BAMIC. There are some specific classification depending on the muscle group we're analyzing. So because there is a wide variability in muscle anatomy, it has been proposed some muscle-specific classification system or sub-classifications which might facilitate communication. Okay, similar to what we see on the fracture classification. So there are various fracture classification depending on what fracture and what bone we're talking about. So this has been proposed for the muscle. Do different muscle injury classification depending on the specific muscle group, okay? So there are classifications already for the hamstrings, the triceps surae, the rectus femoris, and adductor longus. These are the most common muscle injuries. There's already an ultrasound classification for the medial gastrocnemius injury, and they just published the same classification based on MRI for the medial gastrocnemius. Personally, I think that this is gonna be very useful, various classification systems for different muscle groups. It's gonna facilitate communication with the athletes and the sports medicine. And what will change the treatment according to these classifications? Will this change anything? Well, we know that with a normal MRI, there is a more simple recovery protocol, and the athlete's going to have a faster return to play. If there's an intramuscular or subfascial hematoma, this allows us to aspirate. We know that aspiration of the hematoma allows a faster healing of the muscle. So every time we have a hematoma, it's indicated to aspirate to increase the speed of the recovery of this muscle healing. We don't know what amount is considered to aspirate. So this is still the good sense, okay, on what we consider indicated for aspiration, okay? We know that a complete tear of a tendon or the myotendinous junction is going to take a long recovery time and might warrant a specific recovery protocol from the physiotherapists. And all other injuries, which are the great majority of them, are going to be subject to an adapted physiotherapy protocol where the clinical parameters are important. So all the other injuries, the clinical symptoms of the patient, the functional examinations are going to be important to choose the adequate treatment, okay? And to answer the question, should we classify or not classify? Personally, for professional sports, yes. Professional sports, we need to classify. We need to give the prognosis both to the athlete, both to the medical team. So I think it's very important to classify. For amateur sports, of course, an amateur runner wants to know how long he's going to take to come back running. So this is going to depend a lot on the interaction between the radiologist and the medical team that's treating this amateur athlete. And even the amateur athlete, sometimes they want to know a prognosis, how long approximately it's going to take to come back to his activities. Okay, so for professional sports, definitely yes, we should classify. For amateur sports, depends on all of this that I talked about. Okay. So the take-home messages, we know classification provide a prognostic information in muscle injuries. We know that muscle strains with a normal MRI has a fast recovery. Complete muscle tears has a slow recovery. And the connective tissue involvement, the intramuscular tendon involvement, has a slower recovery time. And there is little consensus on a comprehensive and evidence-based system. And classification, MRI is more used, although ultrasound might have a role in specific muscle classifications. We did this article on imaging of muscle injuries, MR and ultrasound correlation, where I talk about a lot of this that was that I showed in this lecture. If you're interested, you can take a look in this article. And this finalizes my talk. I want to thank you, all of you. These are my social media addresses. I like to discuss cases. I like to show the cases, and feel free to contact me, show cases, discuss about musculoskeletal radiology, which is what I really love to do. Okay. And thank you once more for the opportunity to share a little bit of our experience here. And I'm happy to answer any question. Thank you very much.
Thank you, thank you, thank you so much, sir, for being there. It was so good to see the entire spectrum, covering the ultrasound and the MRI, and how both can help you reach to a classification as well to decide the prognosis. So I think I really, really enjoyed the talk. So thank you so much. There are few Q&As. Do you mind if I read them out to you?
Of course, we can.
Yeah. So there is a question that how can you easily differentiate a tear from an edema?
Okay, this is a excellent question. In ultrasound, it's easier to differentiate edema from a tear because we can see architectural distortion on ultrasound. On MRI, it's more difficult to see a tear, to differentiate the tear from edema. Let's start that every muscle edema is a kind of tear. Maybe it's a partial tear. Maybe it's there is a true discontinuity. So sometimes it's not easy on MRI to differentiate if we don't see fluid, okay? So we don't know if there's a true discontinuity. On ultrasound, it's easier. We can see the architectural distortion of the injury, okay? So on ultrasound, it's easier to see this architectural distortion than on MRI.
Okay. So the next question is, do you use some specific maneuvers while doing an hamstring ultrasound?
Yes. It's very important to be perpendicular to the area we're analyzing, okay? So sometimes if we're not really perpendicular to the area on the hamstrings we're analyzing, we might not even see the tear, okay? Or we see it in a less defined way. So this is the first thing. The other thing I do is dynamic maneuvers. I do first muscle contraction. I ask him to contract the hamstring, and then I ask to do flexion and extension of the leg. Actually, I do actively the flexion and extension of the leg to see if that area of hyperechogenicity fills with fluid. Sometimes we can see doing these dynamic maneuvers, contraction of the hamstring or flexion extension of the lower leg, we can see a feeling of fluid, showing that there is a real discontinuity. It's not only muscle edema there. So this is another advantage of ultrasound compared to MRI, is allowing to do dynamic maneuvers to see if there's a true discontinuity or it's just the muscle edema.
Okay, okay. Then the next question is, what are your go-to sequences on an MRI in suspected muscle injuries? MRI sequences which you would prefer.
Okay, so we have to do axial images for any muscle injury. I do both T2 FATSAT and the normal T2 FATSAT. A T1, there are some people that prefer a proton density. I prefer the T1 to see these muscle injuries. This is on the axial plane. On the long axis, the longitudinal planes, I use one coronal FATSAT and one sagittal FATSAT. Okay, so these are the basic sequences. So I do the T2 FATSAT in all planes and the T1 in the axial plane.
Okay. Then there's a question. In your experience, do you find ultrasound and MRI to be concordant?
Yes, for I usually find a concordance between them, except on the proximal deep muscles. So for the proximal hamstring and proximal adductor, I think MRI is a little bit better than ultrasound, although most of the cases we can also see on ultrasound. Okay, but I'm more confident for these muscles, the proximal deep muscles, to on the MR results. For all the other muscles, I think they're really concordant. Even for the low-grade injuries, we can see on ultrasound. This is going to depend, of course, on where the patient feels the clinical symptoms. So you have to scan this area on ultrasound in order not to miss an injury. Okay, so for deep muscle injuries, I think MRI is a little bit better than ultrasound. For all the rest, I think they're the same on experienced hands, of course.
Yeah. No, so obviously we know that how big your experience is now. Uh, so there is another question which have been asked by 2 or 3 attendees actually. Uh, how often do you do hematoma aspiration? And is there some technique which you follow specifically, like, and how do you handle organized hematomas, like if the patient has come a bit later?
Yeah, every time it's possible, I do aspiration. When it's possible, it depends on the size of the hematoma. We don't know, there's not a criteria in the literature when we should aspirate, okay? So every time I would say more than 10, 15 ml, we suggest aspiration in order to heal faster. If it's not a professional athlete, if it's not something that needs to heal faster, we don't do the aspiration, okay? It's better to do in the first 5 to 7 days. Otherwise, it's going to be organized and it's going to be very difficult to aspirate. So I try to use, in these cases, larger gauge, lesser gauge needles, okay, and more caliber needles, and try to aspirate. And even though it's very difficult to aspirate, I don't inject any product to try to dissolve the hematoma. I prefer not to do this. So I usually aspirate in the first 7 days. After that, I usually don't indicate because it's going to be very less likely that we'll be able to aspirate because it's already organized.
Yeah, exactly. And as you mentioned, somebody's asking the same question. Do you do PRPs also for muscle injuries? And if there is an hematoma, then do you prefer PRP still?
Yeah, this is very interesting. I was talking I was doing a PRP the other day. It's very controversial PRP injection in the muscle. And the patient, because we take blood from the patient and then we inject. And we also sometimes aspirate the hematoma. And the patient asked me, why are you taking out blood and then putting blood back? So, and then I have to explain, no, this is not blood, this is plasma. It's a more concentrated. It's gonna help to heal your muscle. And so usually I do aspiration. We do the PRPs for the professional athletes, although we know that there's not very good evidence on it, but the professional athletes, the doctors and the athletes, they want to do it. Our results are various results. It depends on the kind of sport, the kind of patient, the kind of PRP. There are a lot of PRPs in the market, some PRPs with low concentration of platelets, some with more concentration of platelets. We know that it needs to have more than 10 billion platelets to have some healing effect. So it depends on also the type of PRP system that you're using. Okay, we used to use one that's called Angel, which gives us more than 10 billion platelets for these athletes. And every time there's hematoma, we aspirate. So yes, we're using for the professional athletes only. Again, little evidence in the literature.
And do you also do, so somebody has asked on the same lines that what is the difference and your experience about PRP versus dry needling?
Yes, the dry needling is gonna facilitate the anti-inflammatory. It's gonna bleed inside and in theory help the healing of the muscle, but also little evidence as the PRP. Okay, there's a little bit more evidence in the literature for PRP, this highly concentrated compared to the dry needling, but it's also an option in terms of muscle healing. Okay, so there are other indications for dry needling. Pain is the main indication, but there is also little evidence in regard to muscle healing using dry needling.
Then, so I think how to differentiate a partial versus a full thickness muscle tear.
Okay, so we have to differentiate if it's as I showed a complete muscle tear, the classical grade 3 injury. It's very rare. So sometimes there is a complete tendon tear, which is worse than a complete muscle tear. Okay, so a complete tendon tear has a poor prognosis compared to a complete muscle tear because the tendon is more difficult to heal than the muscle injury. Okay, and how we differentiate? We have to see this continuity of the tendon and the loss of tension. You remember I showed some longitudinal coronal or sagittal images where the tendon is curving. Yeah. This indicates that it's a complete tendon tear as well. Okay, so always don't look only on the axials, look on the longitudinal images to see if the tendon is curvy, lax, with loss of tension. Yes.
So on that same line, so if you find some full thickness tear, in your experience, do they also heal spontaneously or usually require a surgery?
If it's so surgery is well indicated for the tendon attachments in the bone. So we know for hamstrings, for rectus femoris, but there is controversy if there is intramuscular tendon tear, a complete tear. Usually they do not indicate surgery, but there are some centers that they are indicating surgery even for these intramuscular tendon tears. Although this is very controversial in terms of healing time. Some studies show that the healing time does not improve with surgery in the intramuscular tendon. Totally different, as I said, for the tendon attachment in the bone. So there is a big advantage to operating the tendon attachment, the tendon tears when they attach in the bone. but there is not so much evidence when it's an intramuscular tendon injury.
Then one of the last two questions, probably more because we have a long list. So we have almost covered up. Which classification system do you use in your routine practice? And do you follow some structured format for muscle injuries?
Yes, I use the BAMIC. I think it's the more it's not the more simple, but it's quite simple to use in the day practice, and it gives the doctor, the athlete, some prognostic information. Okay, so I think it's the one it's more useful for us. There's a disadvantage of it. The BAMIC was described only for the hamstrings, but I adapted to the rectus femoris and sometimes even the adductors. For the soleus muscle injuries, I also use the BAMIC, and there is the PEDRE classification for the gastrocnemius, the medial gastrocnemius, which I try to use this kind of classification for the medial gastrocnemius. Okay, so for the muscles in the upper extremities, then I use the 1, 2, 3 classification.
Okay, okay. And the last question, which I can figure out is there any particular time to do a PRP? Like a duration, like you said, aspiration you usually do within 7 days. So do you prefer a timing to do a PRP as well?
Yes, ideally it's better to do in the first 7 days as well. Okay, so that the healing process initiates as early as possible, and the advantage of PRP initiates as early as possible. So we use in our protocol, we do it in the first 7 days. If we use that highly concentrated PRP, the Angel, which is give us more than 10 billion, then we do only 1 injection. If it's the other ones with less concentrated platelets, then we do 2 or 3. Then the clinical evaluation is gonna help us guide. My experience on this, it's very variable. There are some patients that really have faster recovery with PRP. There are others not so much. So it's really variable, our experience with PRP.
I think that kind of sums up all the question. I think everyone was pretty interested and intrigued by the wonderful talk. So thank you so much, sir, for accepting the invitation.